practitioner. Nurse practitioners are well-trained clinicians who effectively diagnose acute and chronic diseases, interpret diagnostic findings, prescribe rehabilitation treatments and health services, prescribe medications, including controlled substances, and counsel patients on health behaviors and treatment options. So a lot of people don't know and understand what nurse practitioners are. We had the opportunity to meet with legislators in our community that we, as CMP members, visit, and they really don't know what a nurse practitioner is. They believe that we are just registered nurses. Of course, we are registered nurses, and our knowledge is based on the registered nurse, training. But this is why I was hoping that some of the legislators were going to be joining us tonight, so they could understand a little bit more about what we do. The history of nurse practitioners, the NP profession was developed in the 1960s, so we're not new. As a response to unmet healthcare needs, over 50 years of research has consistently shown that NPs deliver safe, cost-effective healthcare with high-quality results. NPs are registered nurses who have master's or doctorate degrees with advanced clinical training and competencies. Close to 90% of all nurse practitioners are preparing primary care, and they are substantially more likely to practice in rural areas, serve as higher proportion of uninsured and Medicaid patients, while contributing to healthcare cost reductions. And this was an article that came on the Desert Sun on August 24, 2016. Some of the facts is nurse practitioners are one of the fastest growing professions in the United States. Over 50% of nurse practitioners provide primary care. NPs constitute a large share of the primary care force in rural areas, regions of California, and in urban regions. Almost 90% of the NP graduates are females, but this is changing, and you're going to meet one of our speakers tonight who happens to be a male. Almost 40% of nurse practitioners work in a hospital, while 60% practice in physician offices or medical groups. And according to the U.S. News and World Reports, jobs available for nurse practitioners will increase 31% by 2024 compared to 2014. So this is really good news. The Institute of Medicine report in 2010 had a report titled "The Future of Nursing: Leading Change, Advancing Health." And they recommend that our country remove statutory barriers and allow NPs to do what they're educated, trained, licensed, and certified to do. The report pointed out that the political decisions of each state are what create such a wide variations to nurse practitioners' ability to work to their full potential. So we have been waiting and hoping that we're going to one day achieve independent practice, especially in California. 22 states and the District of Columbia have addressed this problem by allowing nurse practitioners to practice to the full extent of their training, and is showing its results. Since Nevada passed a law in 2013 giving more practice autonomy to NPs, the Nevada Nurse Association reports nearly a 36% increase in nurse practitioners registered in the state. Unfortunately, California remains one of the most restrictive states to NP practice, and could expect a lower NP growth rate compared to unrestricted states. And we need to continue working on this, and this is why it is so important that we join CAMP, because we are the only organization in California that represents nurse practitioners. So access to care is what we're all about. As millions of Americans have been given access to healthcare insurance through the Affordable Care Act, there's clearly a shortage of primary care providers available to care for them. Emergency rooms are seeing more patients overall and providing an expensive and alternative to primary care. The demand for PCP is expected to rise, and it's well documented that California is already facing a significant shortage of primary care providers. So how are nurse practitioners bridging the gap to access to care? Well, to answer this question, we have three, unfortunately. One of the speakers canceled because she was driving from Santa Barbara, and she said that some of the freeways are closed. But we have three wonderful speakers, and I'm going to introduce each of them one by one, and I would like you to please have a seat in the front. So the first one is going to be Ms. Jennifer Dixon. Jennifer is a board-certified adult nurse practitioner. She is employed by Regal Medical Group and works as a nurse practitioner hospitalist at Glendale Memorial Hospital. She has a bachelor's in psychology from UCLA and a master's in nursing from Cal State University, Los Angeles. Thank you, Jenny. I'm going to bring
Okay.
The next one is going to be Mr. Johnny Moyer. He's a board-certified family nurse practitioner. He works at the San Fernando Community Health Center in partnership with Harvard Recuperative Care Center in Mission Hills. There, Mr. Moyer takes care of the homeless population who has been discharged from the emergency room. Johnny graduated magna cum laude from Cal State University, Dominguez Hills, with a bachelor's and master's in nursing, and graduated once again magna cum laude from Charles Drew MD program. And last but not least, Dr. Lynn Bandera is a board-certified family nurse practitioner. She's an associate director of clinical services and health informatics at California State University Northridge, as well as an adjunct faculty at CSUN Department of Nursing. She has a master's in nursing from UCLA and a doctorate in nursing practice from Duke University. Dr. Bandera. So the format that we chose is each of the speakers is going to speak for a few minutes about what they do, how they are helping to bridge the gap to access to care in our communities. And if you have any questions, please don't hesitate to lift your hand and we'll be happy to answer them. Thank you.
So again, I'm Jennifer Dixon. I'm an adult nurse practitioner, and I was hired to be an NP hospitalist. My focus on the elderly. So these are folks that are, these are folks that are in their 80s and 90s who have multiple comorbidities, COPD, CHF, diabetes, dementia. They live alone. They may have families that are really struggling to care for them. They may even be homeless. And this population is growing as the baby boomers age into it. In fact, it's called the Great Tsunami. So these are those end of life and last years of life are typically the most expensive in terms of health care. So my role when I was hired was really to focus on this group, and I'm always loved my old people. Some people like babies, I like them old. So I was very pleased to work with them. In fact, my master's thesis was regarding Alzheimer's. I'm very passionate about dementia and Alzheimer's and helping families with their loved ones who are have memory loss. So my typical day at the hospital is I round with physicians and we see all the patients. And as we're going along, they'll say to me something like, "Jen, that's one of your peeps." And it is. And I'm really happy to work with I get extra time in the afternoons when I go back and talk to patients, older patients and their families, not only why they've come to the hospital, I try to dig deep. What are all their comorbidities? How do they work together? What's going on at home? What medications? I'll call the pharmacy, make sure that those medications that we think they're on, they're really on. And also do a lot of end-of-life talk, pulse talk, and try to develop a plan with the patient and family so that we can keep them in the home. Once we discharge them, my colleague in the field is a home visiting NP. So that really is bridging a gap from the hospital to home. So for our most vulnerable patients, for example, I had one the other day who came in, she had a stroke in August, she has whole left-sided hemiparesis, she has a PEG tube, she has atrial fibrillation, she's on Coumadin, she's an insulin-dependent type 2 diabetic, and she came in for new onset seizures. So a lot going on there, and she's cared for by one daughter, 24/7. So, you know, she's not able to get to her physician. It's really hard for her to get out of the house. She's now bedridden or in a wheelchair, so we have our home NP visiting her in the home, almost like, you know, the primary care doctor or primary care provider comes into the home. So I think that's a great bridge in that gap, because a lot of patients, when they get older, really have a hard time accessing health care. Another patient I had